All right, thanks everybody for joining. It is 6:05, so we're going to begin now. I've already seen a couple of questions come through in our chat box, so this is great. You guys are already utilizing everything. So thanks for joining. My name is Christy, and I work for Medtronic. And tonight I have the pleasure of hosting this webinar where you'll be able to hear from Dr. Malley. He's both a urologist and a urologic surgeon that specializes in both male and female urology, urologic oncology, and novel therapies for voiding dysfunction, stone disease, ED, et cetera, et cetera, et cetera. So tonight, Dr. Malley will be speaking on overactive bladder, stress incontinence, and urinary retention in light of Bladder Health Awareness Month. He'll also discuss a therapy called InterStim that helps to treat those conditions. And as I mentioned, I work for Medtronic, and that's the company that actually developed this therapy. So while you might not know the name Medtronic, you probably do know somebody who's had a pacemaker, and that's what we're most known for. So without further ado, I'm going to pass the mic to Dr. Malley, but before I do, just a few reminders. Everybody's phones were muted upon entry. If you have a question, please feel free to type it in the Q&A box at the bottom of your screen. All questions and names remain anonymous, and we'll answer these questions following the presentation. So here is Dr. Malley.
Thank you, Christy. Can you hear me?
Yep, we can.
Perfect. Thank you. So appreciate the introduction. I'm a urologic oncologist. I do head our cancer program, but what I also specialize in a lot of is managing urinary symptoms and overactive bladder in particular. I'm a center of excellence for it. So I do get patients from other states coming in for this issue, and it's a pretty common issue out there. I'd say the biggest barrier to getting treatment for it isn't actually not having access to someone who manages it, but I'd say a bigger issue is that it's just not brought up in the first place. I think the two biggest barriers for that is, number one, patients are embarrassed to talk about it. So about half of patients just never bring it up to the doctor, and the doctor, the primary care, et cetera, may not specifically ask questions to the patient about it. So that's one big issue. And the other big issue is that patients don't realize that this is something that is a problem and can be treated, meaning a lot of them think this is just a normal part of aging and don't realize that something can be done to fix it. And usually a couple of years go by before it is brought up to their physician. Hey, Tracy, I think we lost our screen here.
Let me go ahead and share my screen then. 1 second.
Perfect.
Are you able to see my screen?
Yes.
Okay, great. So I will just go at your pace. Let me just widen this. There we go. And you were here, I believe.
Oh, you know what? Okay, yes. So could you go to the next slide? Perfect. Next slide. Yep. So in terms of on the agenda for tonight, it's talking about, one, the pathway, what's the workup done, and more importantly, what exactly is the problem and what are the treatments for it. Next slide. So in terms of this is an extremely common problem. 1 in 6 adults has overactive bladder. To put that another way, we all know someone with diabetes. Well, overactive bladder is much more common than diabetes. Overactive bladder is much more common than asthma. And those are problems we've probably heard more about. And that's the big issue here with overactive bladder. Is it's extremely common. It's just not talked about a lot. And large part of it is, once again, patients don't want to bring it up. They're embarrassed, et cetera. In terms of what exactly is overactive bladder, so it's an issue that does affect both men and women of all ages. And very simply put, it is urgency. I gotta go right now. Frequency, going to the bathroom a lot. And it may or may not be associated with leakage of urine with that sense of urgency. And problems that it causes: loss of sleep. If you're waking up multiple times at night, it's hard to sleep. It impacts, your confidence, self-esteem, has many downstream sequelae to it. Next slide. In terms of very simply put, it's going to what is normal, what's not normal. It's just going to the bathroom more frequently than you should. An average person goes about 8 times in a day. It is definitely dependent on how much water you drink. But in a normal person, if your bladder is working normally, you should be going to the bathroom when your bladder is full. What you should not be doing is going to the bathroom when your bladder is a quarter full, or half full, or 3/4 full. Your bladder should not be giving you the sensation that you need to go to pee at those times. It should only be doing it when your bladder is truly full. And that's essentially the root cause of, or the root issue with the overactive bladder. It's making you go when you don't really need to go. Next slide. In terms of the root cause for this is your brain communicating to your bladder is not as good as it should be. So the root cause is a miscommunication between your brain and your bladder. And what we want is your bladder is full. Now your brain says, oh, squeeze, get this urine out. It doesn't belong here. But what instead happens as we get older and we develop this issue is your bladder says, oh, go squeeze, but your bladder is not full. It's a quarter full, it's a half full. You have still plenty of time before you're full, but it's making you go more and more often to go to the bathroom to empty. But you don't need to go at this time. That's essentially the underlying issue here. Next slide. In terms of there are many things that can contribute to this, including what you eat and drink that can worsen it. For example, if you have coffee or any caffeine in general, soda, coffee, tea, they'll make you go to the bathroom more. Certain medications you take, especially diuretics, can do that. And other things that make you more prone to it as you get older is pregnancy, childbirth, pelvic floor injury. In terms of, there are 3 simple categories of urinary issues that are out there. And I'll talk about each of these, but one is stress incontinence. Stress incontinence is leaking of urine when you cough or you sneeze. Usually guys don't have this unless they've had certain surgeries and things like that, whereas women do have it more frequently. And this issue is a slightly different issue than an overactive bladder, although you may have both. But stress incontinence, it doesn't mean you're stressed out and you leak. It means that with pressure, whether that's coughing, sneezing, lifting something heavy, there's leakage of urine. Next. So the next big category of urinary issue is urinary retention. And this is you don't empty your bladder completely. In extreme cases, you can't empty at all. And in those patients, men or women, you have to put a catheter in to get the urine out. And in many other cases, patients have not complete retention, but incomplete retention. So they are able to urinate on their own. They just don't empty completely. And that residual urine constantly being in there, not emptying your bladder every time, can be a part of a person who has an overactive bladder. Next slide. And lastly, overactive bladder. And we talked about this is essentially urgency, constantly feeling like you got to go to the bathroom, frequency, going to the bathroom a lot, as well as leakage of urine with this urge, I got to go. And before you get to the bathroom, you may leak a little bit of urine. The good news is there are treatments for overactive bladder, and we'll talk about that next. So in terms of, the first is making a diagnosis. So in terms of making a diagnosis, there are many things that can cause an overactive bladder. In most people, it's going to be an issue with that nerve that we talked about, but we do need to rule out a couple of things before then. And the 2 things that most people get as part of this workup is going to be, one is a simple 15-minute study to study your bladder in women, and in men, a slightly different study, but it's a quick, we just basically have you urinate, and that gives us a lot of our answers that we're looking for. And the second is what's called a cystoscopy. A cystoscopy is akin to a colonoscopy, but in a colonoscopy, you put a camera that goes into the colon, you take a look in there, and then you come back out. In a cystoscopy, you basically put a catheter into the bladder. This catheter is fiber optic, so we can see the inside of your bladder, and then you come out. It takes about 5-10 minutes to do. The purpose of it is just to make sure that these symptoms are not caused by cancer, these symptoms are not caused by stones or scar tissue or some plumbing issues. So it's just to make sure that the real reason you have this is a nerve issue and not something else, because other things can cause it. Once we make the diagnosis and we know, you know what, it is an overactive bladder, it's a nerve issue, the first things that we would, of course, recommend are lifestyle changes. Now, most people have probably already done this before coming to see us. Next slide, Christy. In terms of lifestyle changes, this would be diet. And diet really is getting rid of things that can irritate the bladder or make you go to the bathroom more often, like diuretics, i.e. caffeine, coffee, tea, soda. They're going to make you go to the bathroom more. Now, if you do it in moderation, it's usually not an issue, meaning, let's say you have 1 cup of coffee, that's probably not going to make much of a difference for you. Whether you have 1 cup or no cup, it's not going to impact your life too much. But if you have 5, 6 cups of coffee, we would definitely say cut back on that. Don't do that as much. In terms of exercises, the main one here is not so much for an overactive bladder, but for stress incontinence, which is leakage with coughing, sneezing, etc. We want you to do Kegel exercises. A Kegel exercise is the next time you urinate, stop the flow of urine midstream. The muscles you'd use to stop the flow of urine, those are the muscles we want you to squeeze. Now, you just do it once while urinating, so you know which muscles to do. And then once you know which muscles to do, you can be doing it even when you're not urinating. Like any muscle or any exercise, the more you do the exercise, the stronger that muscle gets. Less you do it, less stronger it gets. So ideally, what we have you do is you squeeze that muscle, you squeeze it hold for 10 seconds. You do it 10 times in the morning, 10 times in the evening. And this is for the issue of stress incontinence. Bladder retraining or biofeedback, that's more for an overactive bladder. And that is, let's say your bladder is a quarter full or a half full, and you know you just went to the bathroom 30 minutes ago, so there's no way your bladder is full right now, but you feel like you need to go to the bathroom again. And that is just suppressing the urge to go back to the bathroom. So what we do want you to do is, if your bladder is truly full, we do want you to go to the bathroom. We don't want you to hold it. But if your bladder is not full, you just went to the bathroom 30 minutes ago, an hour ago, your bladder should not be full. And in those cases, if it's telling you got to go, it's a suppressing that urge. And it helps a little bit. It's not going to be a huge difference, but it does help. Next slide. So in terms of treatment options that exist for this condition, for overactive bladder, very simply, there are 3 buckets of treatments. So the first bucket to talk about would be medications, and that's usually where we do start. Meds have their advantages and they have their disadvantages. The advantages, it's just a pill to take. The disadvantages are the potential side effects that come with that pill. In terms of medications or pills, there are 8 options that I have to choose from out there. But really, another way of putting this is these are 8 pills that I can choose from, but more so in a young patient, I have 8 pills to choose from. As patients get older, I really just have 1 pill to choose from. And the reason is, in terms of these 8 medications, they fall into 2 buckets. One bucket is a group of medications called anticholinergics. So 7 medications fall into this group. The downside with this group are it does have a lot of side effects. And you can see here, when they say 72% of people said they stopped taking this medication within 6 months, that's because of these side effects. Those side effects being dry mouth, dry eyes, constipation, and these side effects do prevent a lot of people from wanting to stay on it. But what's not listed here, which is actually a bigger issue, and the reason I generally tend to avoid these in the older age group, by older age group I mean 60 and over, is there was a landmark study that was published in the New England Journal of Medicine. So for those of you who don't know, this is the most prestigious medical journal that exists in all of medicine. Whether you're in urology or internal medicine, this is the journal for all of medicine. And in about 2014, 2015, there was an article published over there that talked about this particular class of medications, anticholinergics. They crossed the blood-brain barrier, and they were linked with dementia. As a result of that study, in the guidelines for managing patients over the age of 60, and there's a big prominent one called Beer's classification, this is one of the first medications that goes on guidelines that is recommended not to give it for patients over the age of 60 because of its link with causing dementia. And for that reason, I tend not to prescribe anticholinergics for patients over the age of 60. The other medication I actually do like a lot, and the name of the other medication is Myrbetriq. What I don't like about it is it's in a class by itself, meaning there's no competition. So in one class you got 7, but I can't really give those with the dementia risk. With this one, I just have 1. Now the good news with this one is it does not cause dementia. Also, for the most part, it doesn't cause dry eyes, dry mouth. It may cause constipation, but not to the same degree that the other class does. So overall, it's very well tolerated. The one potential issue with this class is it may increase your blood pressure, and that's something to watch on. The good news is it does not for most people, but it can be an issue. The downside to it, though, is you do have to be on it long term. But it's a medication that's overall well tolerated, and it's usually my first go-to when a person comes in, and I know they have overactive bladder from a nerve issue. Next slide. So let's say the medication doesn't work. Let's say you try it, and especially that Myrbetriq, the big issue I have with that, really the biggest issue is cost, because there's no competition. It tends to be extremely expensive. Or let's say it does increase your blood pressure, or you just don't want to be on it, long term. You've been on it for a while, it's not helping you as much as you want. We then go to more advanced therapies. Now, the one that is actually going to fix the root cause of the problem, which is improving the communication between the brain and the bladder, is putting this InterStim device. And that is essentially a pacemaker, but rather than putting it for your bladder, rather than putting it for your heart, you put it for the bladder. But the other option that you have is Botox, which is just an injection that goes directly into the bladder. And then the next slide. So in terms of Botox, everyone's probably heard of Botox for the face. People get that because they have wrinkles on the forehead and they don't want those wrinkles there anymore. And what it does for the forehead is it just relaxes that muscle, and as a result, that muscle becomes smooth and it looks like you don't have wrinkles. When we put it for the bladder, it's for the similar concept of relaxing that muscle. So in that sense, it's very similar to the medications or the pills, in the sense that the pills also work by ultimately relaxing the muscle, same as Botox. But it's not fixing, neither of these are fixing the root cause, which is an improper communication between the brain and the bladder. But the Botox does have certain advantages. Mainly, it's not systemic. Like when you take a pill, it can cause problems like high blood pressure. It can cause problems like dry eyes, dry mouth, constipation. With anticholinergic, it can cause dementia. That's because it goes throughout your body and can cause effects. Whereas with Botox, it is truly limited to your bladder. So the side effects are limited to the bladder. What are the side effects with Botox? There are really just 2. One is it may cause a UTI, and that's less than 5%. And the second is it may work too well, meaning it may relax your bladder too much. And if it does, well, you can't go to the bathroom to urinate. If you were to have this, that's retention. You may temporarily need a catheter put in so that you can get the urine to come out. Now, Botox, even if it did work, it's just a medication, so it does not work for the rest of your life. It works for 6 months. So whereas the pill works only for 24 hours, Botox, if it works, the nice thing about it is it's working for about 6 months. But if it were to work too well and cause retention, usually that's only for a month or 2. And only about 5 to 10% of people have that issue, so it's pretty uncommon. And even if it did happen, it's a temporary issue. But for that being a temporary issue for a month or 2 that you may need a catheter, that is a turnoff for many patients. And for that reason, usually if you fail medications or can't tolerate it, the next step that we actually go to is the InterStim device. So very simply put, the root cause of what's going on here is a miscommunication between your brain and the bladder. So really what we want to do to fix this problem is improve that communication. And this is the only thing that can do that. It's not new. It's been there for a very long time. It's been there for, meaning it was originally FDA approved about 23 years ago. So it's been there and an effective treatment for quite a while. Now, it's been improved upon a lot over the years, meaning the original iPhone came out in 2008, but the current iPhone 12 is way better than that original iPhone. In the same sense, this has been improved upon a lot. In terms of just in August, for the first time, we got an MRI-compatible device. So now there's truly no restrictions you have with this. An analogy I give is your phone. Let's say your phone only got 1 bar reception. When we do this, we're stimulating the bladder nerve to work better, and it's as if we go from 1 bar on your phone to 5 bars on your phone. So the same phone with better reception, it works better. You can hear clearly. It just works better. That's essentially what we're doing with this. And in terms of the next slide, the ultimate what we're doing is we have the patient lay on their stomach, and we do a simple test before we do anything to figure out, is this a good option for the patient? And that test essentially involves putting a small wire. The wire is about the size of a strand of hair, and it goes underneath the skin by the patient's tailbone. And it goes a couple of centimeters underneath the skin, and that's the entire test. There's really no risk with this. The wire comes off, and the other end of it attaches to a battery. The battery we do tape to the patient's back. So let's just say the patient had this done today, and today I actually did 2 of them. The patient would then come back 3 or 4 days later. And while they have this taped to their back, it's something that should help them with urination. Or at least in 80% of people, or 8 out of 10 people who have this done, they will see at least a 50% improvement in their symptoms. So while you have this taped to your back, you have less urgency, less frequency, less leakage of urine, less waking up at night to go to the bathroom. So if that happens, we know that this is something that can work for you. So we do a trial, which has really no risk, and it's not. It's basically just taping something to your back for a couple of days. Think of it like a Holter monitor, but unlike a Holter monitor, it's also potentially therapeutic for those couple of days where it's taped to your back. So when you come back in, let's say 3 days later, we would basically just remove the tape, pull the wire out while you're sitting on the chair, and then you can go home. You can just drive home yourself. There's no restrictions you have on that day. But if you, during that visit, if you say, you know what, during these past couple of days I had this tape in my back, I saw a significant improvement in my symptoms, much less urgency, much less frequency, well, we know you're a candidate for this. And if that is the case, we put a more permanent version of this in. And that more permanent version is essentially a pacemaker. Same thing that you've heard of probably a patient getting, maybe you yourself have it for the heart, but we are using it in a different location, obviously. And it's used, by the way, for used by many different kinds of doctors. The same concept is used by heart doctors to fix the heart, by GI doctors to fix the bowel, by us to fix the bladder, by pain doctors to treat pain, by head and neck surgeons to treat sleep apnea. So it's used throughout medicine to fix different things, but the concept is the same. Whichever nerve you put this to, it improves how that nerve behaves. In terms of if you were to have the more permanent one put in, you would come in on a different day. On that day, the first part of the procedure is the exact same as the nerve test, putting the wire in. But it's a much more sophisticated wire, but the first part of it is the same. It's the second part that's different. Rather than taping a battery to your back, we do make a small incision. The incision is about 3.5 centimeters, and it's on the side of your back. And we just put something about the size of a 50-cent coin and just tuck it in underneath the skin. We close the skin up. So at the end, there is nothing physically sticking out of your body, meaning if you were sitting there naked, we would not be able to see a battery, a wire, or anything else there. I mean, everything is underneath your skin. Putting the battery just takes about 10 more minutes than the actual test. It doesn't take very long, meaning it takes about 30 minutes total about. In terms of the this particular procedure, if you were old and unhealthy, about 2 weeks ago, I did it on a 89-year-old lady, 87, 89, somewhere in that age group. For her, we cannot do anesthesia. She's just too old, and I think that would be too much of a risk for her. We can still do the procedure. I just can't do anesthesia. So we do local anesthesia to numb up that area, but she's awake, and we can put the permanent device in while she's awake. And that goes to say how safe and simple this procedure is. So even though it's very effective and can be a long-term solution, it's not a major surgery you're having. It's a very simple procedure where we would just put something underneath your skin. The nice thing is it's a long-term fixing of the problem, meaning the battery life expectancy is about 5 to 7 years. So for the next 5 to 7 years, for 24 hours a day, 7 days a week, it's something that's working to help improve your urgency, frequency, and leakage of urine symptoms. Now, at that time, at the end, 5 to 7 years, the battery will die. around that time. And at that time, we would prophylactically go in and put a new battery in. Changing the battery takes about 10 minutes to do, so it's a quick 10-minute outpatient procedure. This is a great way to fix this issue for the long run. And because you're fixing the root cause of it, unlike treating the symptoms like you do with med or Botox, because you're treating the root cause of it, it's actually the most effective treatment option that also exists. Meaning, on average, it's about 3 times more effective than any of the other treatments. Next slide. So this basically just highlights some of those key points, which is we first do a simple test where we tape something to your back for 3 days to see does this work or not. And about 80% of people will see an improvement in their symptoms. And I mean a significant improvement, at least 50% improvement in their symptoms. And the efficacy of this on average is 3 times better than medications. So it's a very effective treatment, and it's a long-term fix. We're talking about, for about half a decade that it's working to control your symptoms. Next. So in terms of what are the reasons that we do this for? So by far the most common is actually overactive bladder symptoms, urgency, frequency, leakage of urine. But another reason that we actually use this is actually retention, meaning let's say you cannot pee and you don't have any blockage. It's just your bladder is damaged and it just doesn't squeeze well. In that scenario is another scenario that we do this, and that's because this is just getting your bladder to work better. And it just fixes every function in your bladder, regardless of what reason you're getting it. It would get a combination of both of them, right? You had overactive bladder, but it also didn't empty completely. This would fix both issues. In some people, they literally cannot urinate at all and they need a catheter. We've done on some of those patients, and they now stop catheterizing and they're able to urinate on their own again. So it's a very effective option at just getting your bladder to work better. Next slide. And that's it. And one last thing I just wanted to add is there's another indication. There's 2 more indications for this. So one is refractory interstitial cystitis, and that's for patients who have an inflammatory condition of the bladder and they have trouble controlling it. It works for that. And then lastly, fecal incontinence. So fecal incontinence is you have accidents where you have bowel movements where you didn't mean to have a bowel movement. That's because your rectal sphincter is not as strong as it should be. This gives you much better control of that, meaning this nerve, it's actually the same nerve for the bladder and your bowel. So regardless of what reason you're giving it to, you just get much better control over both of those organs. And that's it. Is there any questions you guys have?
Yeah, I did see several questions come in, so I will go ahead and read those off. But I'm going to leave this slide up so that y'all can write down the phone number. There are several locations across Atlanta, from Marietta to Athens, up to Alpharetta and down to Decatur. And so there are several locations, and this phone number will kind of direct you to the main line, and then they can find where you should go. As Dr. Malley very quickly mentioned, but I'll go ahead and emphasize here, he is a center of excellence, and that's not given to just anybody. So that's a very special designation that our company has given to those who hit certain metrics. They have a certain standard of care, and so yeah, so you would be coming to the right place if you called Advanced Urology and wanted to have a consultation. And this was very informative. Thank you, Dr. Malley. So I'm going to go ahead and open up the questions and read them off. So the first question was, why does a person with an enlarged prostate need to urinate so many times during the night?
So that's a great question. One, as we mentioned, so this only impacts guys. Women do not have a prostate, so this is an issue that only impacts guys. And an enlarged prostate. So a prostate's an organ that initially starts off as a walnut-sized organ, but it can grow to be quite large. I've removed prostates that are larger than tangerines, or quite large. In terms of the analogy I give is, think of it like a donut, I mean the shape of the prostate, and that hole in the middle of the donut, urine needs to travel through there. And as you get older, that prostate grows, which means that that hole that urine needs to travel through gets smaller and smaller and smaller. And as a result, your bladder has to compensate by squeezing harder and harder and harder. And one of the symptoms you get are overactive bladder symptoms. Now, this long-term, if you don't treat the prostate, it causes permanent overactive bladder issues by damaging the bladder. But if you treat it early enough, your symptoms can actually resolve by just treating the enlarged prostate, which is the root cause of the problem. And you may not have an actual bladder issue. Even though the symptoms of enlarged prostate may be the exact same as an overactive bladder, it's just a different cause. And the key there is just fixing the enlarged prostate. Early on, usually one of the more common presentations for it is for you, not during the daytime, but during the nighttime, to go to the bathroom more. And it's not completely understood why that is, but it is an issue that's classically seen with an enlarged prostate. But eventually, what started off as I only go to the bathroom much more at nighttime becomes I go to the bathroom at daytime and nighttime. So eventually, untreated does become much more of a chronic, constant issue, not just a nighttime issue. And ultimately, fixing it is fixing the enlarged prostate. But before, we'd of course ask you to just do some behavioral things. Probably the simplest thing to do would be stop all fluids 2 hours before you go to bed, including water. Don't take water. If you have medication to take it with a small sip rather than drinking a full glass of water with it. So we'd first start there. Next, we would say don't do any diuretics in the evening, meaning if you are on a blood pressure medication that's a diuretic, meaning it makes you go to the bathroom, take it during the daytime and not at nighttime. And doing those two things, if it's not helping, that's really, at that point, we have to address it, more than just those behavioral diet things.
So we had another question, just for men, obviously, as well. Is this option efficacious for men with enlarged prostate? What are the pluses and minuses between this procedure versus the UroLift?
That's a great question. This is something that both men and women, obviously, for the InterStem device can get. But in a guy with an enlarged prostate, it may be just a prostate issue, or it may be a prostate and a bladder issue. For men, usually what we do is we just fix your prostate first. In half of those guys, on average, your problems are actually fixed after fixing your prostate, in which case we don't need to do any of this stuff, because if your symptoms are gone, then it's, meaning if I get to fix a person's prostate before it does any bladder damage, then we don't actually need to do this for you at all.
Great, thank you. And then to piggyback that question, will you be talking about the UroLift treatment option, or is that for obstruction concerns?
Well, I can mention it. In this talk, I'm not talking about it, but for those who don't know, so a UroLift is for an issue that's an enlarged prostate. That is actually even more common than a bladder issue, meaning when a man is 50, half of men have that issue. By the time a man turns 80 years of age, over 90% of men have that issue. Now, this issue, enlarged prostate, does cause overactive bladder symptoms, but the issue fundamentally is with the prostate, not with the bladder. But the biggest issue with this is untreated enlarged prostate. It's not just about the symptoms. It's about damage that it can cause to your bladder initially, and then to your kidney, so much so that it can actually put you on dialysis. But the big shift that we have gone towards doing is treating this earlier. And in that regard, we're actually taking a note from cardiologists, in the sense that in the past, cardiologists used to wait until someone had a heart attack. And when they had a heart attack, they would put a stent in to unblock the heart. And the problem with that is the part of the heart is dead after you have a heart attack. They cannot fix that. So you're kind of getting to it, too late. So what they've started doing, cardiologists, they do a cardiac cath. If you have blockage, they put a stent in. They prevent damage to the heart, and they fix you much earlier, which has way better results, way better outcomes. In the same vein, we have stopped waiting until someone's had significant bladder damage before addressing their prostate. In the past, we but we tended to wait a little bit later in the process. And the main reason is we didn't really have a lot of good options that didn't have side effects with the treatment itself, meaning all the treatments up until UroLift came around had potential permanent side effects. Among them was erectile dysfunction. Then in 2013, a URINARY came aboard, meaning it was FDA approved. And here is a treatment option that has zero long-term side effects, including it's the only BPH treatment that doesn't cause erectile dysfunction as a side effect. And as a result, it became a very attractive option for treating an enlarged prostate. And it's fixing the problem so you don't have to be on medications. And since then, that has now shifted as the primary way of treating an enlarged prostate in this country. And the idea here is bladder preservation, meaning we've incorporated earlier in the treatment algorithm so that you prevent bladder damage rather than waiting until there's bladder damage and then treating you. So by treating a person, if we get to you early enough, we actually treat your unblock your prostate, and in that person, they have not sustained bladder damage. And if it's not sustained bladder damage, then you don't have a lot of these urinary issues. After your enlarged prostate is fixed, your symptoms are much better, and you don't need medications, or you don't need to go with an INRSM or any of these things because your problem is fixed. However, for a lot of men, by the time we're getting them, they've already had significant damage to the bladder. For those guys, once we fix their prostate, it's unblocked. If they still have residual symptoms, then we address fixing the bladder. And in the bladder, fixing the bladder, that's exactly where this talk comes in, where you'd first start off with medication, assuming they can get urine out of the bladder and they're not retaining high amount of urine. If they were retaining high amount, we'd go directly to this. But otherwise, this algorithm would apply to you once we fix your prostate.
That was a great explanation. Thank you. We've got another question, and you addressed this, but I'll go ahead and answer it or ask it. I have overactive bladder, but I also have an issue inside my bladder, interstitial cystitis, that causes periodic pain along with very frequent urination. Would this product possibly help with both issues?
Yeah, this product is really, you're the perfect person for this, because I've had a lot of patients where their primary actual issue is not even overactive bladder symptoms, but it's just pain. And we do a lot of things for that, including hydrodistensions, where you distend the bladder, put medications in to help relieve the inflammation, hence relieve the pain. But this is fixing that nerve. And for a lot of people, when you do this, they have significant improvement in their pain. Of course, it will also help you with urgency frequency, meaning regardless of what was the reason you got this for pain or urgency frequency, it does kill two birds with one stone, meaning it can help address both issues.
Great, thank you. We've got another question. It's a little anecdotal, but it might pertain to several people too. So this person is a patient of yours and recently noticed blood in his urine. He's out of the country, so he visited a general practitioner who prescribed antibiotics. Do you think this problem warrants returning to your office soon?
That's a good question. Well, it just depends on what the workup we've done previously. So if I have taken a look in your bladder recently, then it's not as much of a concern. So anytime someone has blood in the urine, the biggest thing that we get concerned about as urologists is we got to rule out cancer. With microscopic blood, the odds of having cancer is only 5%. With visible blood, it's about 20%. So still the odds are that you don't have cancer, but 20% is a high number. We just need to rule it out. But if we've already previously taken a look in your bladder recently, then we probably don't need to repeat that workup. But that's by far the biggest thing. Now, in terms of when you were to have blood, in general, as long as you're able to urinate, then acutely we're not concerned about it, because the big problem acutely would be if you had significant bleeding, your blood clots, it would clog your bladder so you couldn't pee. The blood clots would literally clog it so it wouldn't go. That would be the only true emergency with visible blood in the urine. So anytime someone has blood in the urine, what we ask them to do is drink as much water as you can, because your bladder has your urine has something that will actually fix this problem on its own. But to kind of expedite it, if you just drink a lot of water, the problem will get fixed on its own. And then down the road, what we do is we just do an evaluation to make sure that it's not due to cancer. Now, other things that can cause it, we would rule those out too. But if you've had recently a workup, then we may not need to do that. And if it's truly a known UTI, and that was definitely what's causing it, then also we potentially may not need to do that.
Great, thank you. Another good question. Can slow digestion also cause urinary problems?
So by slow digestion, if you mean just heartburn, there's many things I guess that I can refer to, but in general, your bowel and your bladder are very interlinked. They share the same nerve. That's why we do this. We can actually fix both the bladder as well as the bowel by doing it. So there is, but the true relation to it is still, it's not always the case. Meaning just because you have a bowel issue doesn't mean you will have a bladder issue, although they do go hand in hand a lot of times.
Yeah, and you kind of mentioned this earlier that fecal incontinence or stool leakage is another indication for interstim. And a lot of your patients I know will oftentimes have a dual diagnosis where they have the urinary dysfunction as well as the bowel, and this helps both. In the high 80%, it's helping at least 50% or greater. So another question. This person ate breakfast this morning, had to go mail a package, had to stop and find a restroom, emptied his bladder. 5 minutes later, had to go again, voided the same amount of urine again, mailed his package. When he got home, had to void again. That's 3 times within a 30-minute period of time. Isn't that an abnormal amount of times to void for a normal person? I'm 71 years old and have BPH.
Yeah, no, that's definitely abnormal. In you, it's most likely your enlarged prostate that's causing it. Now, you may also have a bladder issue because untreated enlarged prostate generally tends to cause a bladder issue in almost everyone eventually. Obviously, women have this issue as well, so you don't need to have an enlarged prostate to cause this. If you're a woman in this age and you had it, then we would just say it's probably a bladder issue. But if you're a guy and you have it this age, we'd say it's a prostate issue or it's both a bladder and a prostate issue. In some cases, it may simply be just a bladder issue, but most cases, usually there's a component of it that's an enlarged prostate. It's definitely not normal, meaning if you just urinated 5 minutes later, you should not need to go to the bathroom. To give you an idea of bladder capacity, normally a full tank is half a liter. So normal Aquafina bottle, that's about the size of your bladder. That's a normal bladder capacity for me or a normal bladder. In terms of what's different compared to that Aquafina bottle than your bladder is that bottle, if I go anything above half a liter, it's going to overflow. But that's not your bladder. It's not going to overflow if I go above half a liter. Your bladder is more like a balloon. It can stretch. It can get to be even bigger. But there's a limit to that. So think of it like a balloon, meaning I stretch it. But if I keep on blowing air into that balloon, eventually it'll pop. And that's the same with your bladder. So on average now, in a normal bladder, the most I can probably stretch it to is about 1 liter. After that, it would probably rupture or I would start leaking out urine. So I can't really have more than 1 liter. So, but if you think about it, a half a liter is basically when most people have a strong urge, I got to go to the bathroom, my bladder is full. If you just went to the bathroom, you should not. Half a liter takes a couple of hours, usually about 4 hours to fill. Now, if you're chugging water, it may come sooner, but it's impossible for it to come 5 minutes later. The reason you're feeling like I need to go to the bathroom 5 minutes later is most likely an issue with blockage. And as you get more and more blocked, your bladder has to work harder and harder and harder to squeeze to get the urine out. And by doing that, once your bladder is squeezing above a certain pressure, it's damaging the bladder. And that damage is permanent. And in those guys, once that permanent damage happens, we do, after fixing the prostate, have to address the bladder issue. But if it's caught early enough, we don't have to address the bladder issue because fixing the prostate prevents the bladder issue in the first place. But it's definitely abnormal and it definitely can be fixed. And that's exactly what an overactive bladder is. It's going to the bathroom often. And if you were saying I have a full bladder and I peed half a liter, that's normal. But if you're going and you're not really emptying that much, that's abnormal. And in 5, 10, 15, 20 minutes, half an hour, 1 hour, there's no way you can get a full bladder that soon. That's not going to happen. So that's an overactive bladder.
I appreciate your candor. And I've heard from several doctors in my past, just being in this field, that have said that this is a normal part of aging, and of course commercials don't help any with Depends and things like that. So I appreciate that you're very honest and say, this is not normal, and there are solutions for this. Another question with regard to InterStim, this gentleman asked, can the benefits of InterStim increase over time?
Yes, and in the sense that essentially what InterStim is doing is it's there's a little battery, and that provides electrical stimulation and goes through the wire to that nerve. We may not have the best setting initially, meaning there are different settings that we can change it to. Long term, though, generally speaking, that wire that we put it next to that nerve, it doesn't move, it scars down. And once that happens, we usually find the sweet spot, the setting that it needs to be at. Once we do, there's really no adjustments happening. And it's really probably not going to improve much after that happens. But early on, we may not have it at the right setting, or we may have had it at the right setting, but it may have shifted slightly, and now there's a better setting. So early on, there's definitely room for improvement. But once we have it in the right setting and it's working, then it's usually fixed and it's there for long term.
Great. And this kind of piggybacks that question. This person had a trial or a test for InterStim and fell short of the 50% improvement. So I think you did mention we're looking for 50% improvement in symptoms in order to kind of qualify for the implant. So he said that he fell short of the 50% improvement, did not qualify for the implant. Is it possible to try again?
Yeah, meaning we definitely, we usually don't try it again soon after. We usually give it time. As a person gets older, different things change. So in a person who previously failed, but it was a while ago, we always try again if they want to. So that we can definitely do. And it may have simply been, not that it wouldn't have worked for you, it may have simply been an issue with the placement of it. Meaning if it's not next to that nerve, it's not going to work as well. And it may have been it was next to that nerve, but with moving you into a certain position, and it may have got pulled out somewhere during that trial, so that what would have otherwise worked didn't look like it worked because it wasn't in the spot that it needed to be. Now, the good news is recently, meaning as recently as just in about August, September of this year, we had the latest iteration of this device that just came out. So including that test, the wires we put for that test, the single biggest issues that we used to have with, there's really no risk with that. The biggest issue we've always had with it is it has an easy tendency to get pulled out. And if it gets pulled out, the patient won't see any benefit. Even though it would have worked, been the perfect treatment for them that have fixed their problems. We don't have this issue with the permanent one because the permanent one is completely internal, so it doesn't get pulled out as much. And it's pretty uncommon to have that. And even if it did, there's different settings you can do for it to bypass it. But with the trial, the single biggest issue is that if it gets pulled out, you're not going to see a benefit, even if it otherwise would have worked for you. So usually what we do is if you have persistent issues, we do try it again.
Great. Thank you for answering that. There's another question. How much Botox is used? Different levels, question mark?
Yeah, so Botox, generally in terms of the dosage, there's only two doses. It's 100 units or 200 units. For a person who has a neurogenic bladder, meaning they truly have dysfunction, let's say they have multiple sclerosis or they have a true problem where they catheterize themselves. For those guys, we do the 200 unit. And the issue with that is at that dose, you're gonna paralyze it so that you can't urinate. So we don't want to give that to a person who just has regular overactive bladder but is not catheterizing. But for your typical guy who gets it, guy or girl who gets it, it's at that 100 unit dose, where it's not going to in most people cause retention, although it may, but that risk is low, meaning like 5 to 10%. In terms of, and even if it did, it would be a temporary issue. So it's really, we don't do much in the way of dosing. It's going to be pretty consistent. But what we do differently is we can alter where we inject that medication. Now, we are injecting that medication to different parts of your bladder, but not all parts of your bladder have the same intensity of nerves, meaning there's certain parts of your bladder, especially in an area called the trigone, which is right when you enter the bladder. This is where the bulk of your nerves are. So if you put this medication much more in this area, it tends to be more effective than putting it in other areas. The downside to it is it may relax it too much and is potentially a bit higher risk for causing retention. So usually my practice, what I do is early on, the first time you get Botox, I don't do too much in this area just so that you don't have retention. And it's been many years after that, even at one patient with retention. So it's something I do try to avoid on the first time. But if you don't have retention the first time around, I do put it in that area going forward because it tends to be more effective.
Thank you. Got another question. What is the name of the medication that is best for over 60? I'm on oxybutynin at age 75.
Yeah, so oxybutynin, the downside to that is it's an anticholinergic. So anyone over the age of 60, the medication we would recommend is, the name of it is Myrbetriq. That's the brand name. Mirabegron is a generic name, but there is no generic, so really it's just the brand name. So that's the single biggest issue we have is cost. It can be like $300 a month for some patients. Now, if it's covered by insurance, then it's great because then you can get it and it's affordable. And if it's not, we always have this as an option.
Perfect. How soon can you have sexual intercourse after the procedure, the InterStim procedure is done?
So really the procedure itself is a pretty simple procedure. As I mentioned earlier, for recently a lady who was in her late 80s, we did this while she's awake, and that's not an uncommon thing for me to do while someone's awake if you're unhealthy. And the point of that I'm making there is it's a pretty simple procedure, meaning the entire procedure is me putting something just superficially underneath your skin. And as such, your recovery is quite quick, meaning you take pain meds for maybe 3 days and then you're essentially back to your normal self. But in terms of sex, that's a lot of movement, and we just want things to heal before you do that. So we'd ask it for about a week or so that you avoid intercourse. The reality, you probably wouldn't hurt anything, but just to be on the safe side, just avoid it for a week.
Great, thank you. We're getting several questions that are more pertinent just to the individual themselves. So I'll let you type some answers if you'd like, Dr. Malley, or I can to these specific individuals. But I think that will wrap up the majority of the questions. There was one question about when the recording will be available. That we will probably know by tomorrow or the next day. There is a marketing department at Advanced Urology, and so they'll be able to post it to the website and do what they need to do. But I'm going to go ahead and leave this slide up because you can go to medtronic.com/bladder relief and watch, some of the things that Dr. Malley discussed tonight. So did you have anything to add, Dr. Malley?
No, that was it. Is there any more questions anyone has?
So this one says, to further my question, I had my prostate removed over 3 years ago, plus radiation, wondering if the big C is coming back. So I think that's more of, they probably need to come see you.
Yeah, definitely. In terms of for prostate cancer for that particular person, it's just check with the PSA or a blood test. But the other issue is when you get radiation for the prostate, you have a risk of getting bladder cancer. It's about twofold higher. But usually that doesn't develop for 5 to 10 years after radiation. The most likely outcome is not that you have cancer coming back. The most likely outcome is that you have an overactive bladder. So when you get radiated for the prostate, what it does is it also radiates the bladder. And as a result, most people who get radiation for prostate cancer, not immediately afterwards, but usually a couple of years after radiation for the prostate, do develop overactive bladder. And this is a great solution for those guys.
Great. Well, I'm glad that I asked that question then for you to answer that. There is a person who asked, they do have an InterStim device already implanted. She's not seeing the highest improvement that she would like. When she increases the stimulation, it hurts. And when it's lower, it doesn't work as well. So would you like to answer that?
Yeah, I mean, the main thing we would just say is come for an office visit there because there are two things that we do to kind of adjust it. So one is exactly what you're doing, which is going to the highest setting, but where it's comfortable and doesn't bother you. We don't want it to be painful, obviously, then you'd go down. But the second thing to that is changing the settings, meaning there's 4 different settings. So if one setting, doesn't work, it just may be in the wrong setting, and you just change it to a different setting. And that's something that we can do for you in the office, and we can evaluate and kind of go from there.
Yep, perfect. Let's see. There was another question that I just saw. How long does a UroLift last?
That's a great question. So a UroLift, what it does is it unblocks the prostate, unblocks the bladder by opening up that channel where the prostate is. Your prostate will still keep on growing, regardless of what procedure you do, meaning the old-fashioned TURP, a UroLift. It doesn't change the fact that your prostate will keep on growing. And the analogy I give is kind of like mowing your lawn. So if you cut your grass today, eventually you'll have to come back and cut the grass again. In terms of the LIFT study, which is the original study that got it approved, FDA approved, when they looked at it 5 years after you had it done, about 15% of people, so 15% of people did need to have it redone again, meaning have another UroLift. 85% of people did not need to have it done because it was still working. So the good news is if you did need to have it done again, you could have a UroLift again. But at the end of 5 years, it appears that about 85% of people were still good. They did not need to have it redone. And our data is really limited to about 7 years since it was only FDA approved in 2013. So we don't have more robust data than that. We know with the TURP, it doesn't work beyond 10 years. So it's probably not going to work quite that long. But it's definitely a couple of years for most people.
Great. Do you work with Dr. Kasabian?
I do, yeah. So me and him are the head of our cancer program.
Perfect. I think that is all of the questions. I'm just going to scroll through one more time. These were great questions. I learned a lot myself. Yes, it is. So I'm just going to go back to that last slide. So you have the phone number. A lot of times advanced urology is able to do even same-day appointments. So they're a great place, even just for a consultation, if you've seen other folks but want another opinion or whatever. So thank you so much for all of this information. And I'll leave this slide up, and we will hopefully have that recording soon. But if not, you'll be able to meet Dr. Malley or his colleagues another time. It looks like one more question came through. Oh, okay. Nope, more of a comment. This patient goes to see Dr. Kasabian, and he thinks that y'all are great. Well, perfect. Thank you so much, Dr. Malley. I appreciate it.
Thank you. Appreciate it. Thank you, everyone.
Thanks. Have a great night. Bye-bye.